could now convene the panel that's titled Taking Stock, How Have We Performed, What Has Been Achieved, with Dr. Theodore, Gandi, please, also Professor Samuels, Maisha Hutton, and Professor Karl Theodore. Please join me at the podium. So what we're going to be doing in this session is that we're going to, the form it will take is that there will be four brief introductions, after which there will we'll be open then to questions, discussions, and what have you. Again, without any further ado, I am going to start right off with Dr. Bernadette Theodore Gandi of PAHO. Bernadette, the floor is yours.
Good morning, everyone. Your Excellencies, distinguished delegates, ladies and gentlemen, good morning. Basically, my task this morning is to talk about the report on the UN Secretary General's report, an overview. And a lot of this has already been, actually all of it, has been covered in previous presentations this morning. So my job has been made exceptionally easy. And I am just basically going to summarize, because I know after the coffee break, your sugar may have risen. So just to put it back in context again for this particular presentation. So we have 15 million premature deaths globally. 47% of those premature deaths occur in low income and low middle income countries. We also know that the risk of dying for NCDs differs in different countries. For example, the risk of dying from premature mortality is 8% in rich countries, compared to 36% among poor countries. So we see the disparity and inequities globally. At the current rate of decline in premature deaths, we will not meet target 3.4 of the SDGs by 2030. We already know, and we've heard already this morning, that premature death from NCDs can be prevented using the best buys of other interventions. So we have the technical knowledge, we know what we need to do. The challenge, of course, is getting it done. We've gone through this morning the different paths that has already been taken. In 2007, we had the Port of Spain Declaration. 2011, the first UN high-level meeting. 2014, the second UN high-level meeting. 2018, the third UN high-level meeting, and we're rapidly on the path to 2025 and the 2030 SDG, and we're really supposed to deliver on the SDGs. We have our 9 global monitoring targets, and we've covered that already. And then we have, in 2014, member states committed to taking the following time-bound commitments, and that has already been discussed this morning. By 2015, they were supposed to set national NCD targets for 2025. 2016, reduce NCD risk factors. And 2016, strengthening health systems for NCDs through primary health care. And again, it was mentioned this morning that very few countries have reached where they should be. The national targets, only 59 countries will reach there in 2015, 93 in 2017, and this was mentioned earlier by Ambassador Ratri. We have the progress indicators for 2017, dealing with surveillance and monitoring, risk factors, and NCDs, plans, and management. And again, Dr. Hennis discussed this morning in terms of the progress indicators which have already been defined. But what are the challenges now to implementation of the recommendation? First of all, we have political choices. We have very weak political actions by heads of states and governments. If we were to look at development of national plans for the SDGs, very few countries have actually integrated non-communicable diseases into their national responses in the 2030 SDG agenda. And I think that is critical. I think if you look at many Vision 2030 for many of our countries in the Caribbean, you may not even see NCDs mentioned there and identified. In terms of health systems, we have a lack of access for all to affordable, safe, and effective services. We have a lack of capacity to incorporate the best practices into primary health care. And health systems in the poorest countries do not have the capacity to integrate the best practice into the universal health package. Another challenge to implementation is the national capacities. We lack many countries, especially many of the poorer countries, lack the skill set to introduce measures to reduce consumption levels. For example, taxes and price increases, particularly with respect to integrate policies to establish cross partnerships and develop proposals to increase taxes and measures on alcohol and tobacco. In terms of international finance, the UN Interagency Task Force remains unfunded. Some countries lack the capacity to engage public and private financing partners, for example, the World Bank. And another major challenge is industry interference. We have routine interference with health policy making, work to discredit proven science, pursue legal challenges to oppose progress, and also lobby for responsible marketing of health-harming products. Global actions accelerate national efforts. To scale up its support in weak areas, WHO has produced a number of technical assistance packages. These include reduced demand for tobacco, scale up CBD management in primary care, reduce salt intake, etc. In terms of the assignments for WHO prior to the 2018 UN high-level meeting, WHO was expected to update Appendix 3 of the NCD Global Plan, 2013 to 2020, the best price. This was done May of last year. Develop an implementation plan for reporting on ending tribal obesity. That was completed in May of last year. Develop a global action plan to promote physical activity. That was completed in November. Provide a platform to track contributions of non-state actors to achieving the 9 voluntary targets. This is still ongoing. Develop a code to track official development assistance for technical assistance for NCDs. This was completed in June 2017. Conduct a midpoint evaluation of implementation of the NCD Global Action Plan. This is going on now. Conduct an evaluation of WHO coordinating the Global Coordination Mechanism. This is ongoing. In preparation for 2018, the Global Conference on Non-Communicable Diseases was held in Montevideo. This was already discussed this morning. The WHO Independent Global High-Level Commission on NCDs to make recommendations leading up to the comprehensive review and assessment in May 2018. And of course, the WHO Civil Society Working Group to establish and make bold and practical recommendations on mobilizing civil society, businesses, NGOs ahead of the UN high-level meeting. And we're here today participating in that process. In terms of the global action to accelerate national efforts, we have the United Nations Interagency Task Force on Prevention and Control of NCDs and its members, which coordinates the actions of the various UN organizations. In 2017, more than 60% of UN agencies are members of that group and include NCDs in their mandates. And that is up from 30% in 2014. We have the well-established WHO Framework Convention on Tobacco Control, which is a treaty established and signed by members of WHO. We have for the philanthropic foundations, we have the Bloomberg Philanthropies, 1 billion since 2007, and the Bill and Melinda Gates Foundation, which has committed 288 million since 2008. And they have committed funds to key measures to reduce tobacco demand and align with the FCTC. And the Resolve to Save Lives initiative to save 100 million individuals from cardiovascular disease. We also have non-governmental organizations, and you heard from the NCD Alliance this morning. What are the recommendations coming from that report? Basically, the world is reaching an inflection point. Without significant investment now, premature mortality from NCDs in developing countries will continue to increase, and the world will not be able to reach target 3.4 of the SDGs on NCDs by 2030. And I think from all of the discussion this morning, we're beginning to realize the impact and the reality of that measure. In terms of the economic impact on NCDs, and I'm sure Professor Theodore will talk about that, the impact of NCDs and then the net on gross domestic product, estimated losses in 2015 to 2030, 477.33 billion in Peru, 18.45 billion in Jamaica. We know that the NCD interventions are cost effective. What are the recommendations? We have reached the inflection point. We need to act now. We need to have a paradigm shift. We need to uphold the commitments at the UN General Assembly. We need to encourage more holistic approaches to NCDs within universal health and a broader health agenda. We need to look at the linkages, as was mentioned earlier, between gender and all of the other developmental issues. We need to reinvigorate political action, strengthen health systems to respond more effectively to NCDs, increase significantly financing for national NCD responses, redouble our efforts to engage sectors beyond health, reinforce the role of non-state actors, promote accountability to the world's citizens, and act in unity. We have a long way to go. We are now in 2018. 2030 is not that far away. We have a lot to achieve in a short space of time. So together, let's beat NCDs. Thank you very much.
So I will now ask Professor Samuels to speak to the evaluation for post-Port of Spain declaration.
Thank you, Trevor. Our protocol being observed. Hi, everybody. I'm going to share with you some of the results of the Port of Spain declaration, evaluation of the Port of Spain declaration. So we know we have a big problem with premature mortality in the region, and it's a threat to social and economic development. So the heads of government met in 2007, and they signed the Port of Spain declaration, which, as Dr. Cummings told you, had 15 points and focused a lot on this multi-sectoral action that we've been talking about so much today. Talked about risk factor reduction, healthcare quality and coverage, surveillance, and also launched Caribbean Wellness Day. So we were funded by IDRC in Canada to evaluate 7 years on the implementation of the declaration. And we did that in 3 phases. So the first phase was doing the actual research and evaluation. I'm turning one thing and not the other. Okay. And I'm not going to go through all this, but I'm just going to give you an idea of what it is we looked at. We looked at national and regional trends in NCD mortality, morbidity and risk factors, the national response, the regional response, the international impact, ongoing surveillance for NCD mortality, etc., and financing, which Karl Theodore's group did. So this is probably the most important slide. This is where you can find all the details. We have a wonderful website, onecaribbeanhealth.org, and if you go to click on the different sections, you will get to the report, which is outlining what we did, and then the detailed investigators report, which is like 300 pages long, and only the nerds would be interested, but it's there for your information. So in terms of the national and regional trends, this slide is just to show you the diversity within the region. There are some countries that are improving, and there are some countries that are actually going backwards. So we have a very wide range of responses in the region. An interesting question is why, and we are looking at that. In terms of the national policy responses, so one of the big things that came out of Port of Spain is the importance of the size of the country. You know, small island developing states, whether they're high-income countries or upper middle income, which always are a mix of both, have vulnerabilities because of their size and because of the risk of catastrophic events wiping out a country. Barbuda just came off the map the other day, one hurricane. So we have issues in terms of actually implementation of the Port of Spain mandates and the size of the country. And in this slide here, you will see the percent compliance in red, and you will see the population size on a log scale in blue. And you can see that there's a clear correlation between those two. And it's not a coincidence. It is because in the smallest countries, they lack capacity. There's half a person doing the job that's in some big countries you have 10 people doing. So in terms of our national policy response, what we found was that the highest implementation were in areas where there were protocols or blueprints in existence. So for example, Caribbean Wellness Day, the WHO STEPS Risk Factor Survey, which was supported by CARICOM, and before that, CARIC. The Framework Convention on Tobacco Control, we haven't done great, but we have done something, and there's a blueprint to help us along. The lowest implementation were around diet and physical activity. And then we talked earlier about multi-sectoral action. So in terms of financing, I'm actually going to leave Professor Theodore to discuss that. So he'll talk about that. And then we moved on to the second aspect, which was to meet in, having done the research, we met in Port of Spain in February of 2016. Wide cross-section, lots of people here were actually at that meeting. We presented the results, we got validation of the results, and then the meeting talked about what could be done to accelerate action. And these are the areas that we discussed at that meeting in terms of accelerating action and the recommendations that were made in various areas and domains. And then we went on to the very important phase of dissemination, because we're about translational research. Although I'm from a research institute, which proudly bears the name of Georgia Dean, thank you. We recognize that without translation, the research really is not so helpful. So we spent a lot of time doing dissemination and accelerating implementation. So again, telling you about the website, I'm really promoting this website. And I want to leave with a couple of slides, which is where I'm going to start my second presentation next, later on. We recognize that in CARICOM, we have our biggest problem is with obesity and being overweight, poor diets. Despite being tropical areas, 85% of our adults eat less than the recommended 5 portions of fruits and vegetables a day. We have an extremely high import bill, about 65% on average. In St. Kitts, you import 90% of the food you eat. And of course, this has an impact on the quality of the food that we get. We have had very poor progress on the Port of Spain commitments related to upstream determinants of diet and nutrition, and obesity and diabetes continue to rise. So the goal going forward is to promote sustainable production, processing, distribution, preparation, sale, and consumption of safe, affordable, nutritious, high-quality Caribbean food. I'll talk about that in the new project in a little while. But just to say, with the old Port of Spain declaration, which ran from 2014 to 2017, that there were collaborators from all 3 campuses of the university, University of Toronto, Healthy Caribbean Coalition, CARFA, PAHO, and we were funded by the IBRC Canada. So I leave you with a wonderful market scene from Cheapside Markets in Barbados. Wonderful food to be had for all. Thank you.
having said that, I can't resist my hobby horse. That at breakfast this morning, and I'm looking for fruit, and I did not see one single fruit from Jamaica. It's all imported from wherever. A real challenge. What there was a ballad there? Okay, all right. I stand corrected. So let us move on to the third speaker, Maisha Hutton. Maisha Hutton, the Executive Director of the HCC, is going to speak to achievements and progress in NCD prevention and control, civil society's perspective. So, civil society has an important role in shadow reporting. Maisha.
Thank you. So I just hit my neck. I'm turning and looking at the slides and we'll walk. So taking stocks, we talked about where we are, and what I'm going to share with you is a bit about civil society's contribution to bringing us to this space. Now, clearly the contribution is significant, and I can't cover it all in my 10 minutes, but I'm going to go through some of these snapshots of where we've done well. So from Port of Spain in 2007 to today, we start with a very important event, and that was the Port of Spain Declaration, in which there was a call for civil society to play a central role in the whole of society response. And this was essentially the catalyst for the formation of the Healthy Caribbean Coalition, the first of its kind regional alliance of NCD-focused civil society organizations. The mission of the HCC was really to harness the power of these organizations, which were working actively across the region, to bring them together as a collaborative network in which they could scale their impact at a national level and a regional level. And today we have in excess of 100 members who are NCD focused, so health NGOs as well as non-health NGOs. So the key kind of impact areas have been in the area of service provision, providing services to meet those gaps in the public sector. Communicators, providing evidence-based information to drive the information that they are disseminating through community outreach. They're often reaching grassroots populations, vulnerable communities that are not reached by traditional dissemination methods. And then advocates, lobbying for policy change, lobbying for legislation. And finally, watchdogs, ensuring that there is a degree of accountability, both at the level of the public sector, the private sector, and amongst ourselves. When we make commitments, we need to stick to them. So I'm going to go through a few snapshots of success through the lens of communication, accountability, tobacco control, cervical cancer prevention and control, and finally, obesity prevention. So communication here, what I've done is just shown a snapshot. Now this is largely HCC and our members and the work that we've done in communicating various materials across the region on various issues, including alcohol and cancer, trade policy, childhood obesity, depression, sugar, tobacco control, NCD commissions, sodium, blood pressure control. And this is just a snapshot of the type of communication that we've been trying to endeavor on to ensure that the community at the large throughout the region is informed and educated. And these materials have been produced by members throughout the Caribbean, many of which are in this room. We also endeavor to have this weekly communication platform, the HCC News Roundup, where thankfully all of you send content to us weekly. And it's really an effort to connect the region, to showcase what civil society is doing, and to bring us up to date on key NCD events, both nationally, regionally, and globally. In terms of accountability and that watchdog role, this is an example of something that we've started to do recently. It's called the COPS. It's the Childhood Obesity Prevention Scorecard. And essentially what it does is we've taken a snapshot of the key policy initiatives which address the childhood obesity problem, and we've essentially created a scorecard across each country. So this is a snapshot for one of the countries, Antigua and Barbuda. And we've got 12 indicators which link to our Childhood Obesity Action Plan, which you can see a flyer for over there. And it just allows countries and civil society actors to go into our website and see very quickly, where are the gaps? Where do I need to focus my advocacy? And then where do I need to also support the government in implementation of these policies and legislation. Tobacco control. Now this has really largely been led by the efforts of the Jamaica Coalition for Tobacco Control in Jamaica from way back in partnership with the Bloomberg Grant. And they worked not only in Jamaica, but they worked regionally to strengthen the capacity of civil society organizations throughout the region to contribute to the tobacco control advocacy movement. This document was created by Barbara McGaw of the JCTC, and it really documents the history of tobacco advocacy in the region and the contribution that civil society has made to triggering the implementation of legislation under the FCTC, and also the accountability work that they've done, the shadow reporting, the ensuring that they're tracking what industry is doing, is industry working with government. And they've actually been able to translate a lot of this intelligence in this the way that they operate towards obesity and the obesity prevention sphere now. So quite a bit of lessons to be learned there. This is, I don't want you to look at this and detail it, but it's just, this is from the tobacco control report. It's just something that Barbara did that we thought was lovely. And she's really just shown a timeline of all of the tobacco efforts in the region from 1971 to 2014 when the document's printed. It's very useful for us, and it's a really important regional document, which has a lot to offer. So in cervical cancer prevention and control, we've done quite a lot with many of you in the room through funding from the Australian Direct Aid Program. And this program is essentially around building the capacity of civil society to respond more effectively to cervical cancer and prevention and control in support of government efforts, targeting women who are in vulnerable communities. And this, we've been able to screen over 10,000 women in vulnerable communities across Jamaica, Belize, Guyana, and Dominica, as well as Grenada. So collectively we work together, and in December in Sharjah at the second NCD Alliance Sharjah Forum, we received an award for excellence for access in recognition of the tremendous work that these civil society organizations have been doing across the region to ensure that women who would otherwise not be screened are getting access to cervical cancer screening and education. We were really proud of that. And so obesity prevention, this is a huge issue right now. You saw earlier this morning, Francine launched the Too Much Junk Childhood Obesity Petition. Jamaica is doing a tremendous job here locally around the Are You Drinking Yourself Sick campaign in partnership with the Ministry of Health, again funded through the Global Health Advocacy Incubator. So this is just a snapshot into the work that's being done at the region, being led by civil society. And I'll talk a little bit more later on today about the work that HCC is doing. But I wanted to point this out again as a huge initiative that's being led by civil society. And it's being scaled throughout the region through the CDB project, which is connected to Heart Foundation in Jamaica with 4 other civil society organizations. So lessons learned here can be translated to Belize, to Guyana, to Barbados, and to other countries. So this is a really good example of civil society leading. Before I get into this slide, I just wanted to say, you know, as we sit here, what can we do moving forward to better engage civil society organizations in the work that we're doing in the region? And I think we need to do a better job of engaging civil society from different sectors. So Minister Hutton was here this morning, and he said very proudly, we are working on this initiative in partnership with Heart Foundation Jamaica. So we've seen a partnership between Jamaica Moves, Heart Foundation, and they're leading in collaboration on an initiative. Alafia just mentioned that the HCC was a member of the multi-country project, the Positive Evaluation Team. So again, civil society was a strong partner. So we need as civil society to demonstrate that we have the capacity to partner with government, with private sector, with other funders to deliver high quality output products. And the other thing too is national NCD commissions. These are perfect platforms for civil society to actively participate and contribute to the national response. And finally, last year, Trinidad and Tobago launched the first regional NCD alliance, the first national NCD alliance in the region. So they now have a Trinidad and Tobago national NCD alliance, which we need to replicate in other islands. So in closing, what are we doing to get to that high-level meeting? And this is a replication of a lot of what Katie said earlier. The WHO CSO technical working group, so Trevor sits on that in addition to Katie. We're having this forum, and we've brought you all together to build awareness around the high-level meeting. There are meeting resources. There's an excellent technical document which was developed by Dr. Barnett, which provides a wealth of information on where the Caribbean has come and where we need to go. We'll be producing the CSO statement on high-level priorities, and I hope that you've all received an email asking you to fill a quick survey out to help us to identify those priorities. We worked with the OAS and His Excellency Ambassador Hart around a high-level joint meeting with the Permanent Council of the OSND. And this is again around building awareness for the high-level meeting. We've developed a brief for Ministers of Foreign Affairs, and this is developed by our technical advisor, Nicole Foster, which we will be disseminating soon to ensure that we meet that gap that Ambassador Rattray identified earlier around technical assistance for Ministers of Foreign Affairs. We're identifying champions and success stories. We'll be at the side event, we'll be at the WHA's coming up next month, and we're actually hosting a side event on childhood obesity prevention with NCD Child and the World Diabetes Foundation and the World Economic Forum. We'll be at the preparatory meeting in July, ongoing work with all of our partners, and continuing to provide regional intelligence around this meeting so that we can keep everyone up to date. So in closing, this was our last big meeting in 2017 in Antigua, and this was around advocacy, accountability, and conflict of interest. It was kindly sponsored by the NCD Alliance and other partners. And we're so happy that we're here again this year, and this shows all the energy that we had, and we're happy that you guys are here with us for our 2018 meeting. Thank you.
So the final presentation is from Professor Karl Theodore, who will speak to financing NCD prevention and control in CARICOM, one of our real challenges to this in the entire morning this time.
Yeah, good morning. Thanks very much, Trevor. Good morning to you all, and we had a very rich, a very full morning so far. I want to talk about financing, and we have to talk about financing because we have a lot of plans, a lot of things we want to do, but of course, if we don't get the financing right, all these plans will come to naught. I want to start by saying, well, basically saying, well, why we have to get this financing right too. It's because apart from the fact what we saw this morning, a number of people told us about the number of people that are dying because of the extent of the NCD problem that we're facing. But what is also happening is that our economies are also being strangled. We have some studies, one study is telling us, for certain rather, that the impact of diabetes alone is 3% of the GDP. Another study telling us that the impact of diabetes and hypertension put together is 5%. If we go to the next slide, is a third study by the Economic Intelligence Unit. This tells us that the impact on Trinidad and Tobago was 12%. 12% of the GDP. Now, these, when you hear about the GDP and you hear about these percentages, people say, oh, those numbers sound small. But if I wanted to keep some numbers in your mind, CARICOM, the GDP of the CARICOM countries, when you add it all together, it adds up to $85 billion. 85 billion. Now, 1% of 85 billion is 850 million. 1%. So when you talk about loss of 1% or 2%, you're talking about billions, hundreds of billions of dollars. It is plenty money. So we talk about the NCDs. I know there is a health side, but there is an economic side that is really, really very serious. Now, how do we the funding arrangements we have, and how do we finance the NCDs? We're already a public and private sources. Of course, ministries of health, they provide funding. And in 3 countries, we have specific programs. We have prescription plans in Barbados, in Jamaica, and in Trinidad. And they are directly aimed at funding the NCDs. But of course, people pay a lot out of their pocket. In this region, out-of-pocket spending on health for the Caribbean is really very, very high. We know that WHO tells us that we should not have out-of-pocket spending more than like about 20%. That is highish. But in the Caribbean, the average is close to 40%. In Grenada, for example, it's more than 50%. In Trinidad and Tobago, it's almost 50. People are spending a lot of money out of their pocket on these diseases. And what that suggests, or what that raises, is the issue of equity, because it suggests that people who have the problems but don't have money, some of them are going to be in real trouble. So we have to find a way, to finance this response, which takes into consideration that there are a lot of people who will be facing the problem but will not have the money to deal with it. The context of the financing requirements, there are 3 dimensions of the context. The first is that first we are resource constrained in the region, all the countries. I think there are probably only 2 countries in the region that would tell us that they don't have fiscal deficits. Everybody else is and not only they have fiscal deficits, but they have had fiscal deficits for years upon years. It is a chronic situation. What that tells us though is that if funds are so constrained, it means that when we think of financing, we have to think also about how we're spending our monies, about efficiency. We're going to come to that now. The second dimension, apart from the resource constraint, is the fact that all of us have now accepted that, and as the minister reminded us this one, universal health coverage, universal health access, we are going for that. And what that means, that has some specific requirements in it. Again, we mentioned that a bit more in more detail in the short run. And the third aspect was mentioned a while ago was that some of the countries have introduced national plans to respond. So when you think about the financing, you have to think that there's a context, that there's a framework that we have there that we have to keep in mind. The financing, when we are getting thinking about it, how we are going about it, we are saying that there are ways we are doing it, we are financing now, and we have to think about probably modifying what we're doing. And as I think it was the minister again, who mentioned this morning that, you see, if you're financing health, one of the aspects of it is the way we are allocating our resources to the different aspects of what we do. And the allocation to primary care is something at this stage where we're talking about the NCDs, we have to be mindful of. The second thing we have to think about when we're looking at financing strategy, maybe we have to look for a new way of financing, because as we said before, if we are in a situation where a lot of people are spending out of their pocket, but the result for the nation as a whole is not good, we still have a number of people who are really not getting care. It probably means that the way the financing is going has changed. And the third thing we're looking at financing, we have to, as I said, we have to concern ourselves how we're spending the money. In other words, are we spending in a way that the efficiencies are being taken into account? And the last aspect of financing, obviously, is one that faces all of us in all our countries. We all have a revenue collection problem. In some countries, we are not collecting, we are barely collecting. The governments are collecting barely half of the money that they are supposed to be collecting. which means to say that one of the things we might have to do is to raise our voices, you know, to get the governments to go and collect their monies. Now, financing and efficiency, I think they are going together, but for us, the two main things we're going to look at are the strengthening of primary care and the new financing arrangement. I want to talk about just one word about the primary care because there is evidence now which is telling us that the countries that are focusing on primary care, listen carefully, for countries that are focusing on primary care are countries where the growth of expenditure in health is lower. Now, in all countries, expenditure in health is growing at rates and sometimes very, very high rates. But what we are finding is that the countries that concentrate on primary care, they have the lower increases. And that is, and in fact, very recently, for us in the region here, USA did some studies, published 2013, 2014 in the Eastern Caribbean, and they also found that the concentration on primary care raised the efficiency of the health system as a whole. And final point on efficiency is the point that WHO makes, and that is that what they did studies to check, they wanted to see how much waste in health spending there was. And you know what they found? 20% was like a low figure. The range in waste of health spending was between 20 and 40%. So it means that we're talking about financing, but we have to keep in mind that we have to put things in place as well to make sure that what we're spending is not being wasted. Now, I want to pull a few things together. We look at the context, and one of the things that comes out is that if it's NCD prevention that we are looking at, you see, it would mean then that this is not the time when we have to look at for a particular source of funds for the NCDs. That is going to be a mistake. Because the nature of the NCDs are so wide and they affect so many people. What we have to do is to get the funding, the way we're funding our health system correct. If we correct that, we're going to find that the NCDs are going to be well run. Now, this approach is linked to, again, what the minister mentioned this morning, the link between the NCD response and universal health coverage. Now, WHO and PAHO, universal health coverage and universal health access. What they have also made it very clear that in fact the NCD response has to be in that context, and for two reasons. Because the NCDs put on a high plan, put the issue of the access to care very and access. And the thing about universal health coverage and universal health access is this. The idea is that access is for everybody. But we know that in the situation we are in the region, that is not the case. It's what the universal health access and universal health coverage also make the point that people seeking care must not be exposed to financial distress when they're seeking care. With the chronic disease, we know this is one of the problems. There's a number of people who have them are really facing serious financial. So we have to find a way of funding the system which deals with the access problem and deals with the financial distress problem. Now, this then is where WHO and PAHO tell us, based on again the work that they do, that when they look at countries and the way countries are financing their health systems, they have come to the conclusion that social insurance, the social insurance method, that's where you are going to be pooling funds together from different sources and providing this thing for everybody. That social insurance approach is the approach that works best. And in fact, and they add to that, that the countries that tend to rely on out-of-pocket spending are the countries that have the worst set of results. So it means to say two things we have to get a financing system that makes sure that out-of-pocket spending is not important to how care for NCDs is being financed, and a system which ensures that the social insurance approach, which involves the pooling of funds so that everyone will get care, is the approach we will take. And that is what I want to talk just a little bit about. Now, in the region is aware of what the WHO has been saying. And in fact, a number of the countries in the region are in fact looking at social health insurance. Now, I think in the second one is I want to make it, because what we want is a financing system that, I'll say, addresses the access issue and addresses the financial distress issue. But it means then that if you're looking to prevent NCDs and control them, you can't be looking for a financing system that focuses on your hospitals. You can't do that. I think that is one of the things the region has to come to terms with. That we cannot have a financing system that puts the hospitals center stage. The financing system has to put primary care center stage, and the national health insurance, which a number of countries are now looking at, is the one that seems to be going there, because it is a cradle-to-grave system, and it tells us that we could get a system which would provide access and make sure that no financial distress is there. Here we have in the region, we have 10 countries that have already gone national health insurance, and we have 9 countries that are at the moment looking at going for national health. And that I think is progress, because 15, 20 years ago, these numbers would not have. The national health insurance, I want to take very quickly in a few minutes how it works. It works very simply. You see, what you have to do, if your focus is on chronic diseases, it means that you set up a system where the package of services that will be covered by your insurance will be dominated by the problems that you have. And therefore, in our case, the chronic diseases are going to feature very high in this package. Having decided on that package, you get a cost to the package. Then the package is funded. Now you have 3 sources of funding. The government puts into the pool, the business sector puts into the pool, and people who are working people put into the pool. Now, and the pool so the pool is created, but the system is also built on something that we call a health information system. Now, the health information system, I cannot overemphasize how important it is, but this is the instrument, this is the basis on which we are going to be able to because what the system does, it tracks every transaction that takes place between provider and patient. So it means that we have the opportunity to know exactly what resources are being used, when it's being used, and we also have the opportunity to know what the impacts are. So that health information system, it becomes crucial. But the important point is that the national insurance system, by highlighting in the package the services that are relevant to prevention and control, with this, when the system is set up, and it's set up in a way, it's always set up in a way, there is an actuarial model that is at the back of it, so that you can keep track, you can make sure that the system remains financially viable, you know when the system is getting into trouble and you know the things that you probably need to do. So we're setting up a system that is sustainable, so people don't have to worry about maybe the system might run out of funds and they can't get care. So the system is sustainable, but the system also focuses on those services that we know that are relevant for prevention and control. And that, I think, and that is one of the things I think we have to try to get all our government, more of our governments to really to fully understand that when we're talking about financing of the NCDs, we're talking about financing our health system in a way that the services that are required by people who have these problems or who face some of these risks even, that those services are going to be financed in a sustainable way. And the social health insurance is the way that we are recommending to do it. And I really hope that this is one of the messages that we're going to carry to the meeting at the end of the year. Thank you very much.
We've got a couple of minutes for any questions or comments or observations. If anyone wishes to address any issue at all, very quickly. Yes, Dr. George. Can we get a mic to Dr. George pretty quickly, please? Thanks very much. Go ahead, Bernadette.
Thank you. The presentation by Professor Theodore was really inspiring. I think that we need to, the persons who are the fervent believers in NCDs need to make sure that it's a cross between universal health coverage and financing of health. And I think that was extremely clear, because I think part of the challenge with the NCD movement has gotten in the Caribbean is that we have taken a very programmatic approach. So we want, and I use programmatic approach in the broader sense. So we want some tobacco prevention control. We want some issues, for example, child obesity. It must be linked to the broader approach. Governments are struggling, and we are not investing in our primary health care. See? So Professor Theodore is correct. In Barbados, the information suggests that we only spend 10% on primary or preventative models. And I'm sure that's replicated across the Caribbean. So we need to rethink. I think it is an important discussion. And I think the programmatic approach may be one of the reasons why the Caribbean is having the
Thanks. Excellent. Any other observations or comments? Yes.
Thank you very much. I like all of the presentations, really excellent. A round of applause, please. Dr. Karl Theodore, I think the problem is that I wonder if we can separate financing from governance generally. Because one of the difficulty of the ministries of health is that they really do not have much control over the financing issue or the financing mechanism. They take their orders, and I use that without anybody asking me to take that mistake. We take our orders from the Ministry of Finance and the Minister of Finance. So perhaps one of the ways in which we can approach this is really to deal with the ministers of finance, to let them understand. Because we know that the ministers of finance have a fetish for edifices. That is the hospital. And we have to remove some of the fetishes and see if we can get down to the concrete situation. And I'm not talking about the concrete structure, I'm talking about the foundation in terms of strategic foresight, even now, as to how we need to deal with those issues. We have a golden opportunity. They are supposed to be going to the high-level meetings. Fortunately, most of the ministers of finance are prime ministers who do not know much about finance. And there may be an opportunity for us to engage them one-on-one, frontally, for them to understand the importance of where we are going. Primary healthcare, finance that, and look at the whole business of the nexus between primary healthcare and the NCD situation that now confronts us, and perhaps that's where we need to zero in and capture the campaign. Thank you very much.
Thanks very much.
All right, follow.
Yeah, no, go ahead, Jay.
Thanks to the panel, all very good presentations. In terms of the diet area, which Alafia pointed out, we had a red scorecard. Quite a bit of progress has been made with the acceptance of a 6-point policy package for healthier food environments. I'll talk a bit more about that tomorrow. And that is going to be a joint meeting between the health ministers and the trade and economic ministers in July of this year. Let me tell you that is progress. Dr. Cummings, myself, others have been working at that, and it's finally going to happen. And then on the economic dimensions of NCDs, the Caribbean Development Bank quite engaged some of the finances as we begin to build up towards having such a dialogue. So those are two areas where the multi-sector, trying to walk the multi-sector talk in response to this, so we'll update the meeting. Thank you.
Any other comments, Victor? And then Ambassador Tracker.
Thank you very much. In terms of the financing again, we speak about whole of government, whole of society approach. And in terms of multi-sectoral, we have education, we have agriculture, we have sport, all these various ministries that impact on health. But have we costed out, or have we formed a mechanism by which we can take X% of monies from sport, X% from agriculture, Y% from education in terms of the funding of CNCDs, even if it is from an education point of view, and you know, I just wanted to comment on that.
Okay. Rapture. What is that?
Thank you. And yes, let me just reiterate congratulations to all of the folks in the presentations. Dr. Summers, you had a particular graph that I was interested in, and I wanted to just put that some clarity. It was the graph that showed a correlation between the size of Caribbean populations, and I think their institutional capacity to implement on their payments. And right next extreme right of that graph, I think we saw Haiti. And I didn't understand because obviously they have the highest population in the region. And I would imagine because of lack of institutional capacity, they are very low on implementation scale. Something about that graph, I just couldn't understand where Haiti was on that. If you could explain a little.
Yeah, but the graph showed Haiti as an outlier. So with Haiti, it has the highest population, but the lowest achievement of the mandates because of Haiti's peculiar situation. So that was the last point on the slide where you saw the population of Haiti very high and the achievements very low. The rest of the countries, there was a fairly tight correlation between country size and performance.
I think that's all.
I would like to endorse the point on the primary health care as the way to go, both in financing and with the reduction and control of NCDs. The gains that we got with communicable disease was accomplished through primary health care. And speaking like experience in Dominica, the typhoid and tuberculosis and all those diseases that were endemic in the country, it is through primary health care that these diseases, we got gains in them. And I believe if we were to strengthen the primary health care system, even as it is right now, we can strengthen, then we can see not only a reduction in the diseases, but also in the financing. So the shift in terms of spending more on building and reinforcing our primary health care system will go a long way in reducing the cost of it.
That message is coming across so clear on the issue of the Caribbean needing to focus go ahead.
Go ahead. We face an issue at this time in the sense that you have an entire Caribbean region of significant development, very poor economies. So what do? If you have X dollars to spend, where do you address it? Do you address the people in dire need now, or you address the future? And that has been the issue facing the Caribbean governments. Economies, disastrous state, no money to spend, and they're trying to fix both at the same time and not going either well. On the area of insurance, I caution people who continue to push for universal health care insurance and social insurance. Somebody has got to pay for it. The level of taxation in Barbados, for example, is extremely high. The people are overburdened at this time. Somebody must pay for the insurance. Whether it is business or individuals, we must find a way to pay for this. So it is a good idea theoretically, but initially you have to say what gives. And I think that the problem the governments are facing, they have not been able to decide what gives. They're all thinking in their 5-year cycles, not willing to address the long-term future of the region, and that is the biggest problem we face as a Caribbean people.
So very, yes, so there's a significant interest. Go ahead in the back.
Yeah. We agree in principle that primary health care is a cost-effective strategy for addressing the NCD problem. But there are some low-hanging fruits that we are not accessing. The whole issue of health promotion is one that we tend to ignore. Right now, at UMate Center Austin, there's an opportunity for CARICOM states to just build capacity in health promotion. And we are not seeing that kind of response. So there is just less than 1% of the participants who can get some kind of knowledge and skills in health promotion. Just less than 1% of the participants are from countries outside of Trinidad and Tobago.
Okay, thanks. Go ahead, Beatrice, and then Karen.
I'm Beatrice Champagne. I wanted to expand a little bit on what was mentioned regarding the fact that governments don't have money, because it's true. Just about everywhere, I work in Latin America a great deal, and it's also true there. Governments, have stretched budgets, they're looking for additional investment. But I agree completely with the low-hanging fruit, because many of the population-based strategies cost very, very little, and they're not getting implemented. Those are such things as, well, some of the countries here were doing them. There are things like taxation of sugary drinks that was mentioned, taxation of tobacco, and things such as front-of-package labeling, marketing to children, or reducing that. There are many things that can be done. And I was wondering about particularly the role of taxation, because that was not mentioned as one of the potential investments in health. So I would like to possibly hear about that.
Karen?
Thanks. I want to focus on how we're performing, and particularly, and when I was reminded by James about this very good news about this 6-point policy between COTEN and COSON. I'm in the advantage right now in the Ministry of Health. Nobody knew about it. I want to suggest this is a very key role for the Health HCC, to find ways of getting media channels through which we can hook continuing stories, including stories on what the governments have committed to when, why, and when.
Okay, thanks. Go ahead. And Sam, go ahead. Karen, just give me 5 minutes. Not hands.
I just wanted to reiterate the point made by Beatrice about the fact that we can't as a terror health system like the points that we raised, but these are very important points for lack of financing. But the whole point of best values is that they're highly cost effective and they're very cheap. We tax tobacco. teenagers never start to smoke, they never become addicted. Therefore, you get rid of the tobacco and that's the largest step going forward. The reality is that we're measuring the impact of NCD interventions now. We're not measuring what's happened in the last 5 years. We're measuring what's happened for 30 years before. So these impacts actually then trickle through into the future. So if you're not taxing tobacco, limiting alcohol, marketing, junk food to kids, etc., you will never make a difference. These are high positive.
Okay. Yes, I'm going to go question.
Yes, I just wanted to make a comment with regards to the general feeling about primary health care. I to remind, I'm from the OECS health unit, and so the member states of the OECS are the ones in that population, small population trying to achieve these things. And I just wanted for us to be cognizant in terms of financing systems change, that when you have to change systems for small populations, you have to spend a greater percentage upfront for the kind of impact, because the population is only so much of a size. And I wanted to speak to the primary health care. Our primary health care systems were created to combat communicable diseases. So while we want to invest in them, we also need to invest in reorienting them so that they are built, designed to really effectively address NCDs.
Okay, so yes.
I just wanted to add to what Dr. Seeley said, my own former person's group. And I was speaking to a former colleague, and I think what we need to do is to decide how we do a progressive regional campaign to advocate prevention of NCDs. And this could be done if the heads of government take a decision that you must have X number of public service announcements broadcast at specific prime times across the region. The only cost then will be the cost of the production of the ad stand.
Right, I hope someone is making. I hope someone is making a record of all of these comments and suggestions.
Just a quick comment to Professor Samuels. You had a slide on text reading that diabetes and obesity is on the rise. So I believe the WHO Global Action Plan had 2012 as its baseline, where it said halt the rise. So I was wondering whether the PAHO representative, I suppose this data is going to come out as part of the benchmark. So I guess that was an alarming text on your slide there. So that was on that part. And then of course on the financing, which is something very, very close to the work of the World Diabetes Foundation. And I'm anticipating a little bit the panel on Wednesday, where I'll make some short comments about the recently held global dialogue on financing, sustainable financing for NCD prevention. Sure. But this is just to emphasize the importance and the strongly, rapidly emerging conceptualization of financing and partnerships. Even while we're here this week, we will see that emerging conceptual framework being verbalized. And I should say that in Copenhagen, the Lancet launched its series on NCDs and economics, so I hope we can also touch a little bit on that. And obviously the report on integrated care or integrating NCDs with other health program areas. It's another report which is just about to be published, where we will see how primary care, integrated primary care can rationalize, or you can say lower that waste, or whatever it was called in one of the slides on health spending, or say, let's say, leading toward a universal health program. These are critical matters that we need to talk about here in Kingston. Thank you.
Good. So as I said, this fantastic amount of really fascinating and interesting interventions. I am going to, because predominantly predominance of the questions were around financing. I'm going to give Professor Theodore an opportunity to respond, after which we'll bring the panel to a close. And it's fascinating because I noticed we haven't even discussed the issue of implementation deficit. And so one of the things I want to quickly put on the table, even as I hand over, is this whole question of the value of these several technical reports that are produced by PAHO and WHO. And I often wonder, are they really of any value? Do they really, and I may be deliberately provocative, are they really of any value in addressing this implementation deficit? Maybe that energy could go mostly in trying to solve that issue of implementation deficit. But I'm doing that very deliberately to continue to stimulate thought and discussion, etc. Professor Theodore, the last words are yours for the panel.
All right, I just want to have an touch on two of the questions raised. Victor's question, it's a very good question. He says, I think he's suggesting we have different ministries that are also they're impacting on health, and maybe get some of their funds to help with the NCDs. But I think my problem with that, Victor, is that the assumption you're making is that we are looking for a pool of funds to deal with the NCDs. And I'm saying that is not the approach. I think that would be the wrong approach. The approach we have to take is to get the system to fund the health better, and in particular the health to fund the primary care side of health better. And once you get that system in place, you really won't need to get funds from the different ministries. So I think once we give up the idea of looking for a pool of funds, I don't think we need to go to what you are suggesting. Also, Ed raised the point about the cost of the social health. But this is, you see, when I hear people talk about the cost of social health, I mean, the facts are, if you look at data, the work we have done will show you that if you look at the monies people are spending on health now, maybe you add public to private, and you ask yourself, okay, let's get a package that will provide very good health care for everybody, how much it would cost. We have never found, except in one case, and that was a very special, we have usually mainly found that the cost to provide health for everybody is generally less than what we're spending right now as a country. The social health insurance is a national program. It is not a government program. It is a national program. It's a cost-sharing program. People who have it is a solidarity-based program. It means that people who have high incomes will be required to put in a required amount just as how people we have low income. And it is that approach which covers for everybody, so that the social health insurance does not bring any increased tax burden. It doesn't do that. People spending, the government, the amount that is, what we're doing is changing the way the money is spent. Changing the way the money is pooled together in order to pay for health. Instead of government paying for some and other people paying from their pockets, it's put into one pool, and what we find that what is in that one pool covers a good package for everybody without raising the cost of health to the country. That is what we are finding now. I don't think anybody in a reasonable thing will say, if you can get a better level of health for everybody at the same national cost as we are spending now, why would we not go there?
Thanks very much. Excellent. A lot of room for debate. Give the panel a round of applause again.